podcast, we are talking about routinely collected data, how they are used by NHS Trust and need to link data at regional and national levels in an effort to reduce health inequalities and increase health equity. Hi, I'm Katalin, your host for the day, and I'm sitting here with Professor Sarah Rodgers and Wes Baker. A huge welcome to you both. Sarah, you're a professor of health informatics at the University of Liverpool. Would you mind telling us a bit more about your background?
Yeah, sure. Thanks, Katalin. So I began with an interest in geographic data systems, and I did a degree in geographical science. And in that, I used map data attached to different layers of information, and that helped with the ability to analyze the data in a geographic information system or GIS. And that kind of intrigued me, and I wanted to follow that up for my doctorate. And I used GIS methods and something called geostatistics to work out where mosquitoes and ticks would be to warn people of the risk of transmission of malaria or Lyme disease. And then afterwards, I moved on to look more intently at the built environment and how this impacts on our health. For example, housing quality and health, or alcohol availability and health. And it was at that time in 2006 when I began working as a lecturer in population and public health departments and using this routinely collected health data.
We also have Wes, who's the Director of Strategic Analytics, Economics and Population Health Management at Merseycare NHS Foundation Trust. Wes, tell us a bit about yourself.
I work for Merseycare NHS Foundation Trust. We're one of the largest community mental health providers. I have a team of data scientists that work with me to look at data, but to look at addressing health inequalities and how we program equity into new models of care. My background is I was a biomedical scientist first in the NHS, and then I moved into become an accountant in the NHS on the NHS Graduate Management Training Scheme. And it was using kind of financial data and understanding costing data that I then end up in the role I'm now, which is looking at more activity data and how we use that activity, but more from a health economics perspective. How do we get value for the pound of investment we get in, because we have a limited resource, but we want to maximize the impact of that investment. And that's where I always look at stuff. How can we make sure our investment is going further and in maximizing those outcomes for those people as well that access our services?
So firstly, let's just clarify, what do we actually mean by routine data?
Routine data are basically those data that are collected by hospitals, schools, police, government departments. And the original purpose has generally been for some other purpose other than research. So it's more to do with making sure the doctors get paid, for example, that kind of thing. That's how I see it anyway. I don't know if Wes has got a different interpretation.
It's exactly that. We routinely collect information in healthcare. Every time someone accesses a GP, every time someone attends A&E, we code data in different ways. Some of that is for assurance and to meet contractual issues. Some of that is for payment mechanisms. So certain hospitals are paid based on the number of activity and the acuity of the patients that attend, and therefore they need to ensure that they're counting it in a correct way and ensuring that we address and report back to the regulator. So that's, as Sarah said, is as we call routine data, and we have a lot of routine data.
How is this data used? Who uses this data?
I want to use it.
I think it depends. I always look at things in three buckets in healthcare. First is the data is used for assurance. Are we doing what we commissioned to do as an NHS provider? How many patients did we see? What was the outcome of their care? And that's really important that we understand that. So one is assurance. One is understanding the data for future predictions, which probably we're not as good at the moment. And then the third bucket, as I call it, or pillar, is how we use the intelligence with research to help us really understand the segments of the population that are accessing services and change that model of care that we've delivered. Because sometimes we can get lost in silo working in healthcare. We're a mental health community provider. If someone comes in for a mental health issue, we'll just treat the mental health, but we'll forget that they come in with respiratory conditions, may have children who have long-term conditions or have mental health issues as well. But we treat the individual and we forget the other things as well. And sometimes that research bit takes us a step back and makes us look at the whole family, the whole person, the whole population. And that's really important for us to kind of step back a bit. Otherwise, you get stuck with the day-to-day and counting and you lose sight of what you're here for.
Wes's third bucket is my primary bucket, which is the population health bucket, because they're continuously collected, these routine data. They're so useful because even if some policy has changed today, the baseline data, the before data is already there. We have data from before, during and after a change is implemented. So as Wes said about looking at the wider perspective and breaking down those silos that we often work in is so important for ensuring that the population health is improved depending on what has changed in terms of policy and practice. It's a good time travel device.
When it comes to sharing NHS data, recently there's been a lot of pushback, a lot of opting out. So since we're talking about how routine data is being used in research, let's discuss what it actually looks like. So, for example, can individuals be identified through this data, or can anyone just get access to this data?
If I'm accessing the data as a researcher, then all the data have been anonymized in the context of a secure data environment. So as a researcher, I can't identify anybody in that data set. And I don't want to be able to identify anyone. And I'm trusted not to identify anyone because I've gone through my training and I've worked with people in the past who've had access to identifiable data. And I said it's a bit of a burden because if they're working on a cancer registry, for example, they would never give away any information on purpose, but accidentally they might see Mrs. Jones in the grocer's shop and say, is George doing okay with his treatment or something like that? And they having all the data anonymized is really helpful for researchers as well.
From our perspective, every data we collect is governed by data protection laws. We would not give out any data to anyone who requested it. There would be a legal basis of why you're requesting the data. And it's only if it's clinicians and there was a clinical direct care need that they would have access to those records. If I was looking at data for even in Merseycare, the data I would get would be anonymized. I wouldn't be able to see names, addresses, that type of thing. I don't need to see it, as Sarah says. I'm only looking at the certain trends. I'm looking at certain information to inform a decision for operations. We follow strict guidelines and legislation, and that's really important to keep confidence in the public that we are keeping the data safe at all times, and we're not just giving anyone access to the data. You have to run a request in. So researchers who want to access the data sets we have in Cheshire Mersey, they have to put a request in. It goes to a body and they scrutinise it, and rightly so, before access is given. And then when the person has access, they only can see anonymised or what we call pseudo-anonymized data, which is certain things that they have access to. And we also have a level of protection in that we don't go below certain numbers. So we only deal with high levels. Anything above kind of like 10, we don't go below that to stop people from ever trying to find out those individuals as well. So that's another layer, even with anonymized data, to keep people grouped together. And this way, we're not looking at individuals, you're looking at population groups, which is what we're trying to do here, versus looking at one or two individuals. That's not what we're here to do.
So even when people do agree to share their data, there are still a lot of discussions I hear amongst health researchers regarding the limitations of routinely collected data.
One thing that we struggle with is that certain data sets are richer than others. For example, because the way commissioning has worked or the way an NHS provider is paid, there's an incentive to increase your contacts, to increase the coding and to increase the data accuracy. So physical health acute hospitals, when they see patients, they get paid on the activity. Therefore, they do a lot of work to ensure they're getting the activity coded correctly, and therefore they get the right payment. If we look at something like community health services, where you're paid on a block, there's no incentive for you to code any better in terms of your data. And what we eventually find in community health data is the data sets aren't as rich. So I can tell you, and this is a national problem, how many patients have been seen by district nursing, but I can't tell you why. That makes it difficult if you're trying to look at interventions in a community setting and we want to do something, let's say, around diabetes or cardiovascular disease or anything that's in a community element of stuff, and you don't know what that individual's done in that service. So no acuity data there. And similar to mental health, there's some benefits, there's richest data in mental health, but there are gaps in the data as well. So what we find is we don't get a full picture. It's like a jigsaw puzzle that you're trying to bring together by having a lot of data sets from different organizations, because looking at one data set on their own doesn't give you the full picture of what's happened. You have to look at the primary care, you look at the secondary care data, someone's collecting it somewhere. But if you look at it in isolation on just community data, and I was looking at doing a model of care, for example, let's say telehealth services. If I wanted to implement telehealth, how would I know which patients would benefit from that service if I didn't know what conditions we're treating? Does that make sense? So that becomes much more complicated to action. And then the research, if you're looking at anything to do with research on that agenda as well, that becomes an issue. So I think the richness data and variations between providers and different settings causes a big problem for us when we're trying to look at this, especially as we're trying to move to that left shift of moving demand from secondary care to more primary prevention and community care.
So is this where data linkage kind of comes into the picture and becomes helpful?
Yeah.
We'll move on to that in a second.
It's really nicely follows on from what Wes was saying about the prevention aspect. And to illustrate another limitation, when I've used the GP data to identify common mental health disorders, what we found is we've used a validated algorithm, which means that this is a bit of code to extract the symptoms, treatments and diagnoses that people have when they visit their GP that are related to common mental health disorders such as anxiety and depression. And the validation was against a survey that was conducted in the community. So we asked people how they are feeling, and we identified if people had anxiety and depression in the community separately. And what we found was this healthcare utilisation from used against the GP only picked up 70% of the anxiety and depression that was in the community. So looking at the healthcare utilisation, it's a blunt tool. Even looking at the GP data, you'll only pick up so much of the health issues that are out there and the burden of health in the community that is actually converted into healthcare utilisation, a bit like Wes was saying earlier. And so even though the study I did looked at 2 million adults and followed them up for a decade, which is the benefit of using routine data, I think the limitation is that we know that it only included a certain proportion of those people who had common mental health conditions that we're interested in.
So basically, if people don't go to access treatments, they're not going to end up within that data set, and we just leave them out.
Yeah, that's right. And we might want to ask people about their mental health and their well-being as well as a positive measure, as well as looking at the rather negative measure of the burden of mental health. We can actually look at their positive well-being to see how people are feeling good about themselves as well.
Another thing that I always wonder about is what's the difference between routine data and big data?
I think what's happened more recently is that the term big data has come into common use in the past few years. And I think it was originally used to describe very, very big data sets from astrophysics, for example. And I think this has been mixed up with the routine data more recently. Secondary data, administrative data, all these different terms. And it's probably not technically correct to use it, but I guess it does give an impression of a really big data set that isn't collected through a survey or a focus group for 20 people or a survey for 200 people, but it's got 2 million people, or the whole of the population of Cheshire and Merseyside, for example, in it. So it's just, I guess people can identify with that expression.
Yeah, I think it's as Sarah said, the term big data in healthcare probably stems where providers stopped looking at their own data and then looking at everyone else's data together, versus where previously we would just look at our own data set because that's what we've always done. We've always looked at patients accessing our services, but we've never looked at, okay, how many people access our services, access other services as well. Big data is a terminology where you're starting to look at wider data sets than your own. And I think that gets confused because it may not be what we truly classify as big data, where we have everything in there, which is probably an ambition to get police, housing, voluntary sector organisations, real-time data from apps and everything that's coming through. That's where we'd like to be in the future. What we probably have at the moment is just the health and social care data sets that we're working with, and we classify these as big data, but it's probably not big data from a perspective of, but everyone thinks that everything's in there. But the ambition is to get to that place, because I think that's where we can really start to see the whole person. And as Sarah said, in the limitations aspect, if you don't know somebody has got something until they access a service, then that is it. The unmet need of those people will be lost to you. But once you augment new data sets in, you'll be able to find them.
Yeah, so this brings us nicely to data linkage that we are increasingly hearing more and more about. So can you talk to us about that a little bit?
In Cheshire and Merseyside, COVID-19 offered us an opportunity to bring all the datasets together because there was a relaxation of the IG rules to allow us to do this. It's one of the benefits that we had from COVID was allowing to connect this dataset together. Previously, we had pockets of this in Liverpool, in Cheshire, in Wirral, maybe St Helens, but it wasn't across the whole of the integrated care system. And what we needed to have is a system where we can see the whole person, because people don't stay within places. You know, if you live in St Helens, you might access care, for example, in Aintree Hospital in a different provider altogether. So by bringing everything together, you start to see the whole picture. The problems in the past we've had is where I call IG as being a blocker. Information governance has been a big issue for us in the past. And it's because I think there's been a culture in some organizations where the professionals who are there to provide support and develop the strategy around data and insight became more like compliance police, where they're telling you, no, you can't do this because this is legislation. But the legislation isn't there to tell you can't do it. It's to keep you safe. As long as you follow the right process, the right legal gateway, and you're doing it with the right case study of why you're linking the data, so there's a reason for that, then there's no reason why you can't bring data sets together. I'm not talking about linking data for the sake of linking data, but it's more important about why you're trying to link that data, the case study of what will it do once you've linked it. And what we've had in the past is you go to meetings and some people sit there and tell you, you can't do it because it's a mountain to climb, you have to do this, you have to do that, and they just block you all the way through. And I think there's a culture change that's starting to happen now where those people who used to say no are starting to say, well, actually, we can do it because this system did it and this is how they did it and this is the legal gateway they used. So people are starting to move forward with these conversations to bring the data in there in a safe way. And that's been the process that we've followed in Cheshire Merseyside. So the momentum now moving to bring new data sets in is moving at pace. But previously, I used to try to do this and it was very difficult before COVID. But then you hear other places are doing it and you think, well, why is it can be done in that system, given they're all England and we're all following the same legislation, but it can't be done here. And it was just around a culture within the organisation of those kind of people, what I call compliance police. Organisations need to change strategically from the top down to ensure that there is a push strategically to allow us to link data in the right way, legally, ethically, or correct, but not that the information governance people aren't just there to say no, because that's not the right way. That's not the way forward. And we're not going to help people and we're not going to develop new models of care. We're not going to support citizens if we have that approach. So there's a balance of having the right governance, but not going too far where you would basically do something to block data that could potentially save someone's life. It's getting that balance of safety.
Well, it's good to hear that there's movement in the right direction and that something good come out of COVID as well.
Wes has definitely got that right about the changing culture that's needed, and I'm really pleased to hear that it's changing. I think that's what I'm seeing as well, that's starting. I know I'm working with the NHS ICB for Cheshire and Merseyside, and they've now got a push to have the household linkages and bring your own data sets in to meet the other data. So, for example, our Groundswell project can bring environmental data based on the household to meet these other data, because we know the hospitals don't cause people to become sick. It's the wider environments that cause people to become sick, and their wider determinants of health, as Margaret Whitehead developed in that famous rainbow diagram. So it's about their work environment and their housing and their education. So it's so important linking those other data sets to the health data to see what impact those have on the health outcomes. And I think that is really important. So we are pleased that things are moving in that direction now.
Through routine data and through these linkages, linked data sets, we have been measuring health inequalities for quite a while now. But how can routine data and linked data actually help us address health inequalities and increase health equity? What's the trick there?
What we've done in Merseycare as a provider is to look at those service users that consume the biggest resource. And we have a small proportion of our service users that are consuming 50% of our contacts. And I'm talking in the region of about 4,000 people. And then you have at the bottom of the tier about 141,000 people who have one contact a year with us. So very small contacts. What we're looking at is allocative efficiency. as healthcare, we don't have a limitless pot of money. We have a limited resource, but it's ensuring that we maximize the value and support those people that need it the most. So how do we program that equity to those groups of people? And that's the same when you look at on a system level, doing work on a cohort called complex lives or complex households. Because we've used the household data that Sarah said, we can start to look at those households that in a place, and there's small numbers, we're talking about in some cases 3,000 to 5,000 households, and they are consuming the biggest resource. So if you look at the Pareto analysis, that 80-20 rule, it will apply in any place across England. And they are probably getting the worst outcomes. So they're not getting great outcomes. Their care is fragmented and siloed because they're accessing multiple services in a different way. If we supported them in a very care coordinated approach, and we also focus on preventative measures for their children so they don't follow in the footsteps of their adults, because a lot of the adults have drug and alcohol issues, mental health issues, asthma, diabetes, cardiovascular disease, all of that. And their children have asthma as well. Then we're stopping that generational issue in the prevention aspect as well, but also keeping those families safe so they're not accessing services multiple times. That hopefully will start to reduce our demands and free up resource and increases capacity for us to support other groups of citizens in our population. And I think that's the key, using the intelligence in a very different way. Where previously we would have been in the assurance, this is about using actionable insights. How do we use the data to create an action on the ground that improves their life expectancy or improves the outcome that they get by accessing the services? So in healthcare, we're obsessed with counting contacts. So everyone counts contacts. I'm interested in counting patients. I want to know how many patients have access to service, where they're from. Are they from deprived areas? Did people from a certain demographic have a poorer experience? Do people from BAME communities have a good experience when they access a service? Are we culturally sensitive in our services? So these are the questions that we should be asking. Otherwise, if you just count contacts, you miss the person. And I think for me, it's all about taking it back to the individual and the citizen. And by looking at the whole person and the family unit, as Sarah said, looking at the household data, it's really important you don't miss the family. Because when we look at data, for example, we've done a lot of work at looked after children. And one of the biggest issues is parental mental health. So you're more likely to be looked after as a child if you have issues with the parents, and parental mental health is really poor. So understanding those risk factors means that we can start to think about interventions that can support that family and stop that child becoming looked after.
I definitely agree with all of that, but just thinking from an evaluation point of view, I think health inequalities are sometimes not brought into a bigger population evaluation quite as they should be. So just thinking about the impact of gentrification on some analyses, you could conclude, if you don't do the analysis in the right way, that some kind of policy work, when in actual fact all of the unhealthy people have been displaced and gone somewhere else, and basically now we're counting all of the healthier people living there. We don't know that the unhealthy ones have moved out and the healthier ones have moved in. So we can see that the population in an area might have fewer hospital admissions, but we might be falsely attributing this to a new service or policy rather than a change of the population that's actually happened. And I guess the reverse is true too. So just thinking about really robust analyses that take into account the people nested within the homes and how those move around over time and space. So to make sure you're counting the right people in the right homes at the right time.
Well, obviously our aim is to increase health equity considerations. So in line with that aim, what would you want from each other or from each other's services and organizations in the future? What is your vision for the next step?
I suppose it's going to be different for Sarah and myself. For me, healthcare historically in the NHS has been very reactive. We react. I call it driving the car through the rearview mirror. We use historical data and we don't actually look forward. We need to be more predictive and prospective in our approach. What's happened last week is gone. We need to know what's going to happen next week, in the next 2 weeks. How can we address that demand that's going to come through the door and ensure that we give the best care possible for those individuals? That's the space that we need to now move into. It's fine to collect intelligence to understand what happened last month, but more importantly, because we can't change that, we can change with the patients we're going to see coming through. It's the gap that we need to start to work in using the insights that we've driven. You know, when you look at services, we need to understand the impact of different services and the impact of policy making in that service. So if you look at, for example, autism, for children who have autism, it takes you 2 years to get assessed. You know, you're on a waiting list for 2 years. So what is the impact of that? Well, kids will end up going to self-harm because you don't get a diagnosis. You then access crisis services. Crisis services is quite expensive. So when you access a service at a higher cost, it's because we don't have the right facilities in a community, or we've not invested in that element of care. So commissioning has to change to say, well, if we invest in having people with quicker diagnosis of autism, especially for young girls who mask their autism when they're in primary school, and then when they hit secondary school, they end up in a crisis because the hormonal aspects kicks in, and then they end up with no support. And that's a key that we need to invest. And also looking to invest more in community mental health teams, especially in CAMS or child and adolescent services. And that's a real key investment. We're not getting enough investment coming through into mental health services, and more equity in funding in the NHS. So historically, funding has gone to the acute providers, and it's missed out primary care, it's missed out community, and it's missed out mental health. And people who access acute care, who are from more deprived areas, have mental health issues, have issues with social care. So you're not going to address the problem with rising demands by not tackling the issues where the funding needs to go. So I think this is the future where I see this intelligence being used as a provider and a system, an integrated care system now, because all funding now is central in Cheshire and Merseyside, how we use that funding going forward. So there's 3 types of solutions we put in. Efficiencies as a provider we can make to make things more efficient with us and as an organisation. But a big area is allocative efficiency, how we use our staff to make sure we get the best outcomes for patients. And then finally, there's another efficiency that we need to focus on, and that's distribution efficiency, addressing the historical underfunding in areas and start to invest in those to get more staff in those areas, especially when we know that there's issues that are consistent. Some of that can be driven locally or through a place, but some of it will need to be come through nationally. We need to raise this nationally to ensure policy changes and funding starts to come into areas as well. And looking at not just health, but voluntary sector organisations, because they have a big part to play in supporting people in community services as well. And I think that funding for them, having long sustainable funding for them rather than short-term funding, can help.
I think that's really interesting what you said there, Wes. And I think we're more aligned possibly than you thought, because I would take that fact that we shouldn't be at the reactive end and maybe raise you one, because I think taking an even longer term perspective in terms of prevention is what my research is about, in terms of stopping people from becoming poorly in the first place by preventing certain conditions, by keeping them, walking around and a little bit active, by making sure that we've got adequate, good quality housing, good quality parks that people want to get out into, making sure they've got a good education, and all of those factors. If we get those right at an early stage for children, then hopefully we can stop them from getting sick in the first place and needing any of our hospital services to some extent.
Routinely collected data and bigger linked datasets are needed for clinical decision-making, as much as population research, to help treat and prevent ill health. Follow #ImplementEquity for further discussion on the challenges and work linked to the data usage in addressing health inequalities.